variability is talking about. So there's 1/4 chance that when a woman has sex, she's going to conceive. Then we have fecundity, that is ability to achieve live birth. The other one is pregnant, to be pregnant, that's 25%. While this one is live birth. After getting pregnant, then the pregnancy is delivered. That is within 1 month, there's about 1/5, that's 20% chance for a woman to have a live birth after intercourse in one menstrual cycle. So infertility has public health perspectives. We can look at it from like in three subheadings. Number one, the epidemiology of infertility. About 10 to 15% of couples worldwide experience infertility. But we say 10 to 15%, it's a lot of numbers. So millions of couples experience this problem. So it's a public health problem. Southeast Asia and Sub-Saharan Africa have the highest infertility rates. Then for an average of 6.8 births per woman, Nigeria has fallen. That is from 1978. Nigeria used to have like 6.8 average of birth rate. That's the fertility rate. Now in 2023, it was found out to be 5.8. So the fertility rate of Nigerians is decreasing. So there is higher chances. Okay, there are higher cases of infertility among our women and men too. Then infertility varies with location. Studies have proven that women in rural areas have more fertility rate than women that live in cities. I think you can agree with me if I say when you look at the couples in the rural areas, you see that they have more number of kids than their counterparts in the cities. Then it's also found out that uneducated women, women that do not have up to secondary school education, tend to have higher fertility rate than educated women. Part of the reasons they mention in their discussions of the results is that because awareness of family planning and age difference. Then there's also studies that prove that poor people tend to be more fertile than wealthy people. And according to Adebawale, that he found out that in 2020. Then about 10 to 15% annually, couples trying to conceive fail and require medical intervention. So that's why it's very important we understand this infertility and understand the management, so that we bring laughter and joy to a greater number of this percentage. Then the other part of the aspect of the public health of infertility is social and psychological impact. Although both men and women can be infertile, but society and cultures, it's everywhere, squarely mostly blame the women, even when they are not tested, even when it's not proven that they are the infertile partners in the relationship. The society now blames them and think that they are the ones that have the problem. So this one can lead to emotional distress, marital conflict, social stigma, depression, and so many other things that can affect other health parts of the couple. Then we have in the light of this, you will have to develop like initiatives to address this kind of stigmatization and stereotype. Then we have health disparities. Despite the advent of technologies and drugs, still mostly this treatment is accessible to people that live in the cities and the rich people. The poor and people in the rural areas tend to lack access to this kind of treatment. So it's very important for our government and other non-governmental organizations and the community in large to balance this inequity in health access. So what do you require for fertility? There are certain requirements that have to be met for couples to be fertile, number one, we have to have production of healthy egg and sperm. The woman has to produce a healthy, viable egg, and the man has to produce healthy and viable sperm. Then there should be an envelope tubes that allows sperm to reach the egg, meaning that the fallopian tube have to be patterned, have to be open, and allow movement of sperm the point of lodging to the point of fertilization. Then the sperm's ability to penetrate and fertilize the egg. The sperm has to have the requisite energy and the enzyme that is supposed to break the cell wall of the egg. So the sperm has to be healthy and viable. Then implantation of the embryo into the uterus. After fertilization, the embryo has to be able to implant itself in the uterus. Anything that affects this can affect the pregnancy success rate of the couple in question. Then finally, healthy pregnancy. A woman can be pregnant with all this, everything number 1 to 4 is okay, but if an accident happens along the way, then the pregnancy can be terminated or aborted. So these 5 conditions have to be met for fertility to be in place. So the etiology, as in what are the things that cause infertility? What are those things that cause infertility? We have causes and we have natural cause. So couples with unknown etiology can be categorized as unexplained. They have unexplained infertility or normal infertile couples. They are called normal infertile couples. That is, there is no scientific reason that can suggest that they have problem. So that is normal infertility. Then there are other causes or risk factors that can now cause infertility. For example, have an advanced age. Like I mentioned before, that women above 35 years have diminished ovarian reserve. I mean, their eggs are the number of their eggs is getting lower as they age. So that even though men, there are studies that confirm that men as old as 90, 100 can father children, but still there are studies that suggest that says there is reduced fertility rate in older men too. Then there's environmental and occupational factors like exposure to some metals can cause infertility, or occupational factors. People that are very stressed, a very stressful job, or people that for example, bus drivers that sit on heat, it tends to kill it tends to reduce the quality of their sperm. Then we have a toxic effect of substances like marijuana, tobacco, and other hard drugs that affect the fertility of men and women. Then excessive exercise, people that tend to, athletes that are tricks of having infertility. If you exercise too much, then there's also diet associated with extreme weight loss. People that are obsessed with weight loss. People that have anorexia nervosa, for example, a mental health disorder, that they are obsessed with their weight. They always don't want to eat and they want to slim down, can have this case of infertility. So these are the risk factors that people need to watch out for to be healthy. Then now after that, we'll look at female factor infertility. And then what are those things that affect women that can cause infertility? We have number 1, we have ovulatory dysfunction. That is when the woman cannot ovulate due to 1 or 2 problems. Then we have structural dysfunction. And structural dysfunction, we have like cervical, whether the cervix is having problem, maybe the cervix has cervical stenosis, where the cervix is already jammed, is closed. It will not allow passage of sperm down to the fallopian tube. Then uterine, the uterus can have problem and it cannot accept implantation of embryo, or can have tubal problem, dysfunction, where the tube is closed. Either the egg cannot pass the tube or the sperm cannot pass the tube. That is also another factor. Then we have peritoneal factor that has mostly do with infections, either TIDs, endometriosis, and others. So these are the things that affect female factor infertility. Then we have, so number 1, we mentioned ovulatory factors. So under ovulatory factor, that is a failure failure to ovulate is called anovulation, and it is mostly the highest cause of infertility in women, up to 40% cause of female infertility. You know, when we look at the menstrual cycle, it's regulated by hormones. They will have hypothalamic pituitary ovarian axis that regulates the menstrual cycle. We have the hypothalamus up in the brain that secretes gonadotropin releasing hormones that now descends to the hypothalamus pituitary gland. Sorry, yeah, pituitary gland that secretes gonadotropins, that is luteinizing hormone and follicle stimulating hormone. Now these two hormones now will act on the ovaries to release estrogen and later progesterone. So when there is problem in these axes, either from the hypothalamus or from the pituitary or from the ovaries, one of these cannot produce the required hormone, then there will be a problem. Then that can lead to an ovulation, that is, the woman can ovulate. So there has to be, when we are looking for the reason, you have to look at this. You have to do hormonal profile to make sure that every hormone is adequate. Next slide. So anovulation now results from the disruption of this communication. Like I said, any problem from the hypothalamus that cannot secrete this gonadotropin releasing hormone to the pituitary that releases gonadotropins, to the ovaries that releases the androgens, that the estrogen and the progesterone, there can be problems. So conditions like thyroid dysfunction, what is probably known as goiter, when you have it causes hormonal imbalance and metabolic disorders. Then conditions like hyperprolactinemia, where we have high level of prolactin, which is milk secreting hormone. When you have too much of it, there will be imbalance between estrogen and prolactin. Then condition like PCOS, that is polycystic ovarian syndrome, that affect the ovaries. Then we have conditions like obesity, exposure to chemotherapy agents, aging process. All this can affect the hypothalamus pituitary ovarian axis and can lead to anovulation. So the symptoms are, when a woman has irregular menstrual cycles, she will see her cycle today for 2 days, then it will go off, then she will see after 10 days, she will see 1 day, then irregular, like sometimes it will be months without having, sometimes multiple in 1 month. That's irregular menstrual cycle. It's a symptoms of a disorder. Then amenorrhea, that is cessation of menstruation. Hirsutism, that is a male-like hairy growth. You see a woman with a beard or hair on her chest. That is hirsutism. It's a sign of PCOS. Then excessive acne, that is too much pimples. That's what we call it in our native language. That is pimples. Then it's a sign too. Then we have when there's increased vaginal secretions, it's a signal that there is problem with estrogen. Next slide. So we have seen the ovulatory function factor, where there can be an ovulation because of all those disorders. Then we have structural dysfunction. Oh, sorry. How do you now measure ovulatory dysfunction of a woman? There are methods available to define ovulatory function. Number one, we have basal body temperature monitoring. Normally, there are biphasic changes in temperatures in women before ovulation and after ovulation. There is fluctuations, there is rise in temperature. So women measure their temperatures when they are menstruating, and after menstruating, every day they tend to measure it. By the time they see a rise in temperature, it signals that there will be ovulation in the next 24 or 48 hours. That is the way to measure ovulation. for people that this is important because when you want to time sexual intercourse timing, when you want to time it, you need to know, you need to hit the ovulation time. I forgot to explain when pregnancy takes place. You know, an ideal cycle is 28 days to 35 days. That is a cycle of women, and we take the first day of bleeding and the one of menstruation. So 14 days after that first day, that is when ovulation normally takes place. So, and it's after women ovulate that they can get pregnant. So this is important. This temperature measurement is important for women to know when they ovulate so that they can time their sexual encounters. Then there is a kit that is being sold in pharmacy and other stores that it's called ovulation test kit. Women can measure the level of luteinizing hormone in their urine, and it signals ovulation. For example, now a woman will be monitoring her just like a pregnancy test kit, as a test strip is one strip that has, I don't know how to explain it's a strip for women that are here or for men that know how to measure pregnancy or other, or even malaria, rapid malaria test. The test kit has control and test. So this one too has that, and the woman will be having daily monitoring of her urine. When there is rise in luteinizing hormone, she will see it on the test kit, and it's signaling that ovulation will happen in the next 24 hours, thereabout. That is the function of ovulation test kit. It's very commonly available and self. Uh, then, after the ovulatory factor, we now look at the structural dysfunction. What happens with the structures? Like I mentioned before, that we have four structures that can have problem and block fertility. Number one, we have the cervical factor, like I mentioned. The cervical factors account for about 5.1% of infertility. Can be caused by stenosis or abnormalities of the mucous sperm interaction. When there is too much of a mucus secretion from the cervix, then the sperm cannot pass because of the obviously because of the viscosity. So there has to, and if there is stenosis, that is there is coverage, the cervix is covered, then sperm cannot pass. So cervical stenosis can cause infertility by blocking the passage of sperm from the cervix to the uterine cavity. That's what the cervical factor of infertility is all about. So when you are evaluating women, you have to evaluate the cervix to see that there is no problem with the cervix. Next slide. Then we have the uterine factor. The uterus is the final destination for embryo and the place where the fetus develops until delivery. After fertilization in the fallopian tube, fertilization takes place in the fallopian tube. Then after like 2 to 3 days, it will now roll down to the uterus where it gets implanted. So if there is problem with the uterus, that it cannot receive an embryo, it cannot implant an embryo, then there will be problem with implantation and the pregnancy will be aborted. Therefore, uterine factors may be associated with primary infertility or with pregnancy wastage and premature delivery. Whether it can cause primary infertility, that it can cause total, there won't be conception at all, or the pregnancy can be wastage, can be that is aborted. Then uterine factors can be congenital or acquired. It can be from birth, can be from the parents, or can be acquired as the woman ages. So they may affect the endometrium, that is the muscles of the uterus or myometrium, and are responsible for up to 25% of infertility cases. Then we have the tubal factor infertility, where we are talking about the tubes now. in a woman reproductive structures or anatomy, it's like I don't know how to. I should have provided a picture of it. There's what we call fallopian tube. It is the one that transports the egg down to the uterus. So once there is abnormalities in the tube, whether maybe it's blocked from the uterus side, that is cannot allow passage of sperm, or it is blocked from the egg side, ovary side. It will not allow passage of the eggs down to the fallopian tube. So either way, this can lead to infertility, and this can lead to ectopic pregnancy, that is implantation outside the normal place. So obstruction. Then we have the peritoneal factor infertility. Next slide. We have the peritoneal factor, where we have anatomical defects or physiologic dysfunction of the peritoneal cavity, including infection, adhesions, adnexal masses, may cause infertility. And this can result from this pelvic inflammatory disease. That is why we don't joke with a PID when there's issue. For example, for couples, sometimes when they go for infertility evaluation, they will be told that it's an infection. Yeah, seriously, infection can cause that. So when you treat it with antibiotics, it will work. So things like PID or endometriosis, large myomas, that is abnormal growth, pelvic masses, can all affect this peritoneum and can lead to infertility. So the male factor. What happens to the man now that can affect his fertility rate? Almost 40% of the cause of infertility is from the men. Yes, that is it's a large percentage, 40%. If you have five infertile couples, it means that 2 of those 5, the problem is from the man. That is the literal meaning of the percentage. So it's not always good to query the woman while leaving the man go free. Male factor infertility can be divided into pretesticular, testicular, and posttesticular etiologies. That is from the before the testis. Testis are the 2 balls, are what we call balls in English. That is what we call testis in medical sciences. Then there are causes before the testis. There are causes at the testis, that is at the balls. Then there are causes after the testis. Then so sperm is constantly produced by the germinal epithelium of the testicle. Sperm generation time takes about 3 days, meaning that there is what we call semen and sperm, spermatozoa. Spermatozoa is contained inside semen. The bulk of what we see after ejaculation is the semen. That is what the liquid we see. That is the semen. We call it in pharmaceutical sciences. We call that the vehicle that it carries the spermatozoa. That is the sperm cells. So sperm's production, not the semen production. Now we're talking about the sperm production takes about 3 days, 72 hours. So it means that every day you have new sperm coming in because today is the 3 days of another spermatozoa. You understand what the point I'm trying to say? It's not that I'm saying that sperm takes 3 days to regenerate. If you have the quantities take the time. If you have like 1 million cells of sperm, then it gets to 3 million. So that 1 million, if it gets ejaculated, it will take like 3 days to replace it. Meanwhile, if you have reserve, it will die off if it is not ejaculated. Then subsequently, it keeps on coming. So sperm production is thermoregulated. 2 to 3 degrees less than the body temperature, meaning that when the testicles need to be at this a right temperature for sperm production to be there. That is why I mentioned people like bus drivers. They have low quality sperm because of they are sitting on high pace. They are sitting on their car's engine, and it's burning them up. So it's increases the temperature of the testes and it's killing their sperm. So pretesticular factors. These pretesticular causes of infertility include congenital or acquired diseases of the hypothalamus. It's just like the woman, we do have hypothalamus, pituitary, and testicular axis. So it can be from the hypothalamus that there is decreased secretion of hormones, or from the pituitary, or from the gonad. So such disorders include idiopathic hypogonadotropic hypogonadism, where you have a low secretion of male hormone like testosterone. When you have prolactinomas, when a woman, you see a man having hyperprolactinemia, secreting breast milk, or having gynecomastia, having large breasts like a woman. Then we have gonadotropin deficiencies, where you have deficiencies of the gonadotropins like testosterone. Then Cushing syndrome too is a disorder that causes this hypogonadotropic hypogonadism. So these are the pretesticular. That is from the hormonal production and activities. Then we have testicular factors. Can be genetic or non-genetic, like we mentioned in the case of women. We have a syndrome that's called Klinefelter syndrome, that is the most common chromosomal. Sorry, is a common chromosomal cause of male infertility, and it results in azoospermia, that is low sperm count. So non-genetic, this Klinefelter syndrome is genetic, while non-genetic etiologies, sorry, non-genetic etiologies include drugs like tobacco, alcohol, too much caffeine can affect that. Radiation, infection, trauma. If a man has trauma, maybe when he's a football player or an athlete, or an accident happens and they got hit in that place, that's a factor. Or body corpses, when there are abnormal blood vessels. So as a man ages now, testosterone levels decrease. Just like a woman, when we have diminished ovarian reserve, in men, the testosterone levels decrease. So the gonadotropin levels increase. Then sperm concentration and semen volume change, and libido decreases. These are the things that happens when man ages. So while age affects female fertility dramatically, age affects females much more than it affects men. Males are not affected as much as females. Like I said before, there are studies that have confirmed that men can father children at the age of 80 or even 90. So medications such as antidepressants or some antihypertensive can worsen libido and ejaculatory function. Antidepressants like SSRIs, the amitriptyline, the Flutex, they affect libido. In fact, sometimes they are used to treat erectile dysfunction. So these medications affect men. Then weight may play a role in male fertility due to elevated estrogen and lower testosterone levels. Once there is too much of estrogen and low testosterone, there can be infertility. Next slide.
Hello, fam. Do you want to grab a glass of water?
I think I need that.
Yes, I think we could pause here so that you can grab. Wow. Hello, everyone. Let's just stay tuned. Fam needs to.
All right, I'm back. So let's go to, then we have the post-testicular factors. That is after production of the sperm, from its transport from the storage outward. That is what we call post-testicular factors. Post-testicular factors are those that do not allow the normal transport of sperm through the ductal system. Such factors too can be congenital or acquired. Men who maybe when they are growing up, they were exposed to DES in uterus. Maybe their mothers were exposed, they took this diesthyl while they are pregnant. They now they can deliver a child with a ductal obstruction. That is the vast difference is obstructed and cannot transport sperm, even though it is already produced. There's no problem with the hormones and the sperm's production, but the ducts are blocked and they cannot go out. So congenital bilateral absence of the vast difference. Vast difference is the tube that pick up the sperm from the storage. So there can be a human being, a man that has this congenital absence of this vast difference, and that is an automatic infertility cause. So additional other things that can cause that are infections or surgical procedures. Somebody that has maybe surgery, maybe this BPH, that what we call BPH, and the person undergoes surgery and problem happens maybe as along the way and they cut something. So that is surgical procedures can affect that. Then trauma too can affect that. So after that is the causes of male and female infertility. So now, how do you evaluate infertile couple? You have a couple that maybe a woman and her partner, a woman that is less than 35 or more than 35, they have spent the required time of sexual intercourse and they are still not fertile. So how do you evaluate that? Number one, you have to take the history of them, both the man and the woman's history. You take the physical examination. You will now send for some diagnostic evaluation of the woman and the man. Next slide. So the history, you will ask of their previous medical records. You want to know whether they have diabetes, whether they have hypertension, whether they have this or that. That is the previous medical records. Some of these medical records have a relationship with infertility. Previous pregnancies and the outcomes for women, whether she has a whether she has a primary infertility, that is she has never conceived, or is secondary, she has conceived before, or now she is not conceiving. The frequency of intercourse, of course, you have to know how many times they have sex in a week or in a month, and the time they do have that sex, so that you know, like I said, it's only after ovulation and the woman can be pregnant. So there is a limited windows. There are ways to calculate that. So there is if you pass that, if you have sex before those days or after those days, chances are that there won't be any pregnancy. So use of lubricants while having sex. There are some lubricants that are spermicidal, meaning that they kill sperm. So you need to ask the couple whether they use lubricants when they are having sex and which kind of lubricant they use. Use of vaginal douches after intercourse. Some women have the habit of immediately washing themselves after sex, so you need to know whether they have the habit and which douche they use for that. Presence of any sexual dysfunction such as anorgasmia, whether the man or the woman cannot attain orgasm. That is a problem. Normally, somebody has to have an orgasm. So failure to achieve orgasm may signal problem in the hormonal cycle. Then previous semen analysis result, if the man has ever been evaluated before. History of impotence, whether the man in his lifetime was impotent before. Whether premature ejaculation, if the person suffers from premature ejaculation. that is, cannot have sustained sex. Changes in libido, whether the man or the woman find it hard to be aroused sexually. Then history of testicular trauma for the man, whether there was a time they had an accident and they got hit in their private part. Previous relationships too, how many sexual partners they do have, to confirm maybe there can be infections or other things, or the other partners have children with them or not. Next slide. Still part of the history, you take the menstrual history of the woman, how the frequency and the pattern since Minachi, since the day she started having menstruation, how has it been? Has it been regular? Has it been irregular? What is the history? Then what changes? You ask of that, you evaluate the physical hair growth pattern. You look at the frontal balding, whether the woman has bald, whether the man has bald, and acne, any previous pregnancy, and the existence of offspring from previous partners. These are all things that you need to ask. Sexually transmitted diseases are things that you need to ask. Surgical contraception, like whether the man has ever had a vasectomy or tubal ligation for the woman, and their lifestyle, of course, whether they are drunkards, they are smokers, they are athletes, they are this or that. These are the history that you need to check. Next slide. Then the physical examination, you check the BP, the pulse rate, the temperature, the body mass index, the eye examination to establish the presence of exophthalmosis as a result of thyroid disorder. We mentioned that thyroid disorder can cause infertility. Evaluate the thyroid gland too. Breast examination to evaluate the breast development and seek abnormal masses or secretions, especially galactoria. This is to make sure that there is no abnormal changes in the breast, and there is no disproportionate size difference in the size. Then evaluation of the hair distribution, clitoris size to Bartholian glands, labia majora and minora. These are all parts of the woman reproductive anatomy, and other lesions that could indicate the existence of venereal disease like gonorrhea or something like that. These are all physical examination that need to take place when you have an infertile couple in front of you. Next slide. For the man, you look at the testicular size, whether it is too small, whether it is hanging up there. We look at the urethral stenosis, presence of varicocele, whether there are abnormal, blood vessels, history of previous inguinal hernia or tear, that can indicate incidental ligation of the spermatic artery if they have had surgery before. Next slide. So the diagnostic evaluation for the female factor, for the cervical factors, there is a test we call postcoital test, known as the SIM-Hunter or Hunter test, whereby you ask the couple to have sex, then you now examine the cervix, the movement of the sperm down the cervix or up the cervix. So this test is to confirm the interaction of the sperm and the mucus and of the secretion of the woman, to see whether the sperm can actually pass or cannot pass. Then for the uterine factors, you send tests, mostly ultrasounds like pelvic ultrasonography, hysterosonogram, and other ultra ESS that can establish any disorder or abnormality. Next slide. For the ovaries, you do this basal body temperature measurement. It's inexpensive. That is not expensive, and it's accurate, but there can be abnormal changes in body temperature due to the environment. There can be environmental factor that affect that. Then you can do biopsy to examine the endometrium. You can go for serum progesterone to see the level of the progesterone after ovulation rises. It can be measured, and that this is to establish, the concentration of the progesterone in relationship with the estrogen. Then urinary ovulation dissection kits to find out whether the woman ovulates or not. Next slide. Then for the man, you send for semen analysis. How do you do semen analysis? You ask the man to abstain from ejaculation, either through sex or masturbation. You ask them to abstain from ejaculation for 2 to 3 days. Remember, I mentioned that spermatogenesis takes about 3 days. That is for sperm production to take about 3 days. So we ask the man to abstain from ejaculation for about 3 days. They should avoid alcohol, caffeine, or smoking a few days prior to collection of the sample. Then you obtain the sample by masturbation or after sex with a special condom. You can masturbate and get collected inside a container, or you can ask the couple if they are not, the man, if he's not comfortable with masturbation, they can have sex using a special condom so that the sperm can be trapped inside the condom and can be used for the analysis. And now collect it, ejaculate, then analyze within 1 hour. A normal semen analysis excludes male factor 90% of the time, meaning that once you have a normal semen analysis, it means that 90% chance that the problem is not from the man. That is how accurate this test is. So once you have a clear normal semen analysis, your focus should be on the woman. Then abnormal findings can be like low sperm count, that is oligospermia, absent, total, that is there is no sperm. There can be semen, but there's no sperm inside. That is azoospermia, poor motility, or abnormal morphology. Next slide. So this table indicates the parameters of the semen analysis. The volume is between 1.5 to 5 mil. That is the ejaculate. Then the pH should be just 7.2 to 8. Appearance should be whitish gray and slightly viscous. Liquefaction time about 20 to 30 minutes after ejaculation before it becomes liquid. Sperm concentration should be about 15 million sperm per mil. More than or greater than 15 million, equal or greater than 15 million sperm per mil. Total sperm count should be about 39 or more than 39 or more million cells of sperm. Then the morphology, there's a way they do that, and the viability too, there's a way they measure that. Next slide. So causes for abnormal semen analysis. When you have an abnormal morphology, that is the visibility of there's problem with the color and shape of the sperm. You query varicocele, stress, or infection. When you have an abnormal motility, you query immunologic factors, you query infection, defect in the sperm structure, and also poor liquefaction of varicoceles. When it's an abnormal volume, or no, there can be abnormal volume can be two, can be no ejaculate, or can be low sperm. So once it is low ejaculate, it's like Ovina is of the line. Once it's no ejaculate, the causes can be ductal obstruction, Klinefelter syndrome, retrograde ejaculation, that is the ejaculation goes back, ejaculatory failure, the person cannot ejaculate, hypogonadism. While low volume is caused by obstruction of ducts, absence of vas deferens, absence of seminal vesicle, that is there is no enough semen, partial retrograde ejaculation, part of it comes out and part of it goes back, and infection too can cause that. Next slide. So physical examination, you do physical examination for the testicular size, like I mentioned before, for the man, and varicose laboratory tests for testosterone and gonadotropins, that is FSH and LH for the woman. And now you look at the sperm function tests, then you refer to urology when there's problem. If you are not a urologist, now once you identify there's problem, you refer to a urologist for correction. Next slide. Then, like I mentioned before, there are people that have unexplained or uh, natural infertility. 30% of infertile people will have this completely normal workup. Like everything of the woman is okay, and everything for the man is too okay. There isn't any scientific problem. So we call that normal infertile couples. So 30% of infertile couples tend to come out normal. So pregnancy rates in unexplained infertility. That is this normal infertile couples. No treatment. When you leave them without treatment, there's about 1.34% that 1.34% of them do get pregnant and get birth. While treatment with clomid, that is clomiphene straight, and intrauterine insemination results in about 8.3% success. Then treatment with gonadotropins, that is the LH and FSH, that is luteinizing hormones, and follicle stimulating hormones. Treatment with that, it results to about 17.1% chances of success rates. Thank you. Next slide. So treatment of infertile couple. Now we have seen the causes, we have seen the risk factors, we have seen where it can go wrong, and if it is structural problem, you have to refer to specialists for structural correction, that is maybe surgery, or if it is maybe ovulatory factors or factors that have to do with infections or other things, you can go ahead with your treatment. So regardless of the treatment approach, whether you are using drugs or surgery, all couples pursuing pregnancy are encouraged to avoid tobacco. It helps them to cease smoking. They should stop alcohol and illicit substances, and they should limit their caffeine intake. Then the female partner should take daily supplement of minimum of 400 microgram of folic acid. That is, or what we have as folic acid here, it comes as 5 milligram tablet. Yeah, they can still take that. Minimum is 400 microgram to help in preventing neural tube defects. That is, it's a congenital abnormality. Folic acid does that. Then any chronic medication must be evaluated for issues during pregnancy and discontinued for, or switch to safer alternative. For example, if the one is maybe on anti-epileptics, for example, like sodium valproate, which is contraindicated in pregnancy. So you either switch to a safer medication so that the woman can conceive, and there won't be a problem with the baby. Then patients are encouraged to achieve normal weight. We tell them to look at their weight. If they are obese, they should look towards reducing their weight to normal body mass index. So the first in the treatment of unexplained couples or people that cannot ovulate is controlled ovarian stimulation. That is, ovaries are the structures that produce eggs in female. So now there are drugs that can be used to control when and how many eggs are produced. So this is what we call control ovarian stimulation. You are now trying to control it. You are trying to snatch it from the nature and use drugs to control the how the ovaries how ovulation takes place. So is the appropriate approach for women with anovulation. That's those women that cannot ovulate or who ovulate but are still experiencing infertility. So the drugs are administered in doses and schedules intended to develop multiple ovarian follicles rather than one dominant follicle. So in menstrual cycle, we're not talking about menstrual cycle. That's why I didn't take my time to explain that. When that we have in menstrual cycle, we have like two phases. We have the follicular phase and the luteal phase. So during the follicular phase, that is when a dominant egg is produced. So when you are using this in this process, we are using a medication to develop multiple eggs instead rather than one. Now you have multiple, 2 or 3 eggs. You are increasing the chances of fertilization. Instead of all of the sperm to go for one egg, now they have like more than one to fertilize. So you are increasing the chances. You are just increasing the chances, like the probability of getting pregnant. So there are multiple approaches to ovulation stimulation that utilize oral or injectable medications. But clomiphene straight, that is clomid, is the most common drug that is used. Next slide. Next slide. So clomiphene straight is we call it is a selective estrogen receptor modulator. That is the class of drug it belongs to. It works just like estrogen, but it does not stimulate the receptor. It does not activate the receptors. It has affinity for estrogen receptors. Okay, when once one egg is produced dominantly, there will be surge in estrogen. The estrogen level is increased in the body, in the female body, and it will now send signal to the brain that okay, we have now a follicle, we have a dominant follicle, so stop sending follicle stimulating hormone. Estrogen is that hormone that tells the brain that stop sending this hormone. We already have a hormone. We already have a follicle, an egg. So now the brain, that's what we call negative feedback effect. The estrogen is too much in the blood. It will now go and tell the hypothalamus that so stop sending these hormones. The hypothalamus will now tell the pituitary, okay, pituitary stop out the gonadotropin now that is being secreted by the hypothalamus is decreased. Then the pituitary now will now stop sending in follicle stimulating hormone. So what clomid or clomiphene straight does is that it will go and block these receptors on the hypothalamus, these estrogen receptors, so that the natural estrogen cannot bind and cannot tell the brain that we have one dominant follicle. So the follicle stimulating hormone will keep coming because there is no negative feedback. There is no message from the hypothalamus to the pituitary that stop sending. So it will keep on sending. So it will now produce more than one egg, increasing the chances of fertilization when we have more than one egg. So when you start this clomid, you start from day 3 to 5 of the menstrual cycle. That is when you start. On day 3 or on day 4 or on day 5. You take it, you tell the one to take one that is 50 milligram, that is one tablet for 5 days. Either if it is on day 3, it will take off 8 days. That is from day 1. I hope you understand what I'm trying to say. Whether it is from day 3 or 4 or 5, it's taken for 5 days only. So the idea of starting from day 3 is 4 or 5. That is when the estrogen level tends to rise. That is, we have the LH surge. So you will now have your clomid. You have a drug that will now quickly go and block the receptors on the brain, so that estrogen that is going to be too much in the blood will not have a place to attach to. So you will have your continuous supply of follicle stimulating hormone. That is the idea of giving it at this time. So if ovulation is documented, So after giving clomid, you now go ahead and start monitoring for ovulation. That is either temperature measurement or using ovulation test sheets that we explained before. That is the idea of explaining that. So after giving clomid, you go ahead and and monitor ovulation. So once ovulation is documented, but pregnancy does not occur, meaning that the woman has ovulated. If she has not been ovulating, she has ovulated and she has sex and there was no pregnancy. So you now continue in the next cycle. Now you go for the same dose of the clomiphene straight in the second cycle, that is 50 milligram for another 5 days. If ovulation does not occur, that is, if ovulation occurs, you maintain the dose. But if ovulation does not occur, you increase the milligram by 50 milligram each cycle. That is, if you do first cycle, the ovulation does not occur. Next cycle, you add 50, that is making 100 milligram for the same 5 days. If ovulation does not occur, you now add it to 150 milligram, make it up to 150 milligram for another 5 days. So some studies says that after these 3 cycles and there's no pregnancy, chances are that clomiphene cannot work. But there are studies that say you can go ahead and keep increasing up to like 6 cycles. Some studies said you can use as much as 250 milligram of clomiphene, but it has its consequences. But most literature suggests that if it is you do 3 cycles and there's no pregnancy, you switch to alternative drugs. Next cycle, next slide. So the some common side effects of the clomiphene, we have the vasomotor symptoms like hot flushes on the face. That is an example of vasomotor symptom. We have the headache, we have irritability, mood swings because it affects the hormones, nausea, alternate cervical mucus, impaired endometrial proliferation, visual disturbances, less than 2% of patients. This is important so that you tell your patient that if you experience this is the side effect of the drug, there won't be any problem. Then one of the side effects is multiple gestation, which is an advantage to some people. Some even fertile people that are not people that are fertile, they are giving birth to children, but they want multiple pregnancy, meaning that they want twins or triplets or quadruplets. They know they go for this clomiphene and they get sometimes they get what they want. That is multiple either twins or triplets or quadruplets. Next slide. So when you use clomiphene, there is pregnancy success rate ranging from 3 to 8%, meaning that there is for people that have an unexplained infertility, up to 8% of them do get pregnant after use of clomid. So it is frequently combined with intrauterine insemination as an additional empiric method, meaning that you bypass the cervix, you collect the sperm and administer it using a needle directly into the endometrium cavity, so that it will now go to the fallopian tube and fertilize the egg. So this procedure, when combined with clomiphene, it gives better results. So the procedure is timed with ovulation to maximize sperm exposure for fertilization. This intrauterine insemination, it is timed with ovulation. It is done when we are expecting maybe ovulation in 1 day, or when ovulation already took place that very day, because sperm do survive up to 3 days in after ejaculation in the woman body. So even when lodged a day before or 2 days before ovulation, that can still be pregnancy. Next slide. So now this is a summary of the drugs that are used to treat female infertility We have the chlomifene straight, like I have explained that before because it is the most common used drug. That is why I took my time to explain that. Then we have letrozole, which is also an aromatase inhibitor. Aromatase is an enzyme that that cleaves these gonadotropins. So this aromatase inhibitor is now go and stop this enzyme that reduce the enzyme. Now it will now reduce the quantity of estrogen and increasing the level of follicle stimulating hormone. Just like chlomifene does, chlomifene works from the brain. It will keep, it will stop, okay, it will stop the estrogen from binding with its receptors. That will result in higher level of follicle stimulating hormone. While letrozole, it inhibits this aromatase inhibitor that now that deactivate or clips the gonadotropin, that is the follicle stimulating hormone, and the LH, so that we now have low level of estrogen and high level of follicle stimulating hormone. And when we have high level of follicle stimulating hormone, you have multiple eggs maturation, 2, 3, or 4, or even 5 eggs at the same time. So indications, when do you use this letrozole? You use it in when a woman has a polycystic ovarian syndrome, that is PCOS, or when there's resistance to chlomifene. You use chlomifene and it doesn't work, you can now switch to letrozole. Or in people that have an unexplained infertility, or people that have endometriosis, these are the candidates for this letrozole. The dose is 2.5 to 7.5 milligram daily for 5 days, just like chlomifene. It gives, you take it on day 3 to day 5 for 5 days. Then some of the headache side effects are headache, fatigue, and dizziness. Then we have the human MG and FSH and LH. This they are called gonadotropins. They directly stimulate the ovarian follicles by bypassing the hypothalamus and the pituitary. That when the FSH and the LH are the one that cause FSH is the one that causes maturation of these eggs. So they are already formed synthetically. You can have them as injectables. So if you cannot use chlomifene to increase them naturally, or you cannot use letrozole to increase them naturally, you can have them synthetically and just administer to the woman. And somebody said the voice is off. You cannot hear me? Hello? Someone said the voice is off. All right. So if you cannot use chlomifene and letrozole to increase these hormones naturally, you now administer them externally. We have them in prepared form. You can inject, and they'll now go and maturize your follicles, more than one follicle, and have multiple follicles. You have more chances of fertilization and more chances of getting pregnant. Some of the indications are when you have PCOS or responsive to oral treatment with chlomifene or agents or letrozole, you use these drugs. But the major side effect is that they cause ovarian hyperstimulation. They overstimulate the ovaries, which is also another problem. Next slide. Then we have the human chorionic gonadotropin. This one, it mimics the gonadotropins like the LH and the FSH. So they are injectables. They can also, just like the gonadotropins work, the FSH and the LH, this one they mimic them, and they trigger more maturation of more eggs. So you have this, you use this, they mimic luteinizing hormone. Luteinizing hormone is the one that helps in shedding of the egg. So that is at the final hour of the final maturation of the follicles. So you use them so that it will now increase all those matured eggs and will now be released, and you increase the chances of your fertilization. Then we have metformin. Metformin is an anti-diabetic. It's insulin sensitizer. Why do you use metformin? Is when a woman maybe has PCOS and has insulin decrease in sensitivity to insulin. So she has like resistance to insulin. So, and that resistance to insulin is one of the causes of infertility. So you use metformin to increase the sensitization of this blood cells to insulin, so that they will now pick up the insulin and to lower your chances of infertility. People with PCOS, they do have this problem, and people with insulin resistance, they do have their agents for people, their agent or candidates for metformin. You can start with the lowest dose of 500 milligram to even 2,000 milligram daily. You titrate the dose from the lower dose to the highest dose, and while watching the effectiveness. Some of the side effects are GI upset, vitamin B12 deficiency, and others. Then we have carbagoline. Carbagoline is a dopamine agonist. You know, we mentioned that hyperprolactinemia, where too much prolactin can cause infertility. So you need a drug that will now stop that block that prolactin production. So that is where carbagoline comes from. That is, it reduces prolactin levels in cases of hyperprolactinemia. The dose is 0.25 to 5 milligram twice weekly. It mostly comes as 8 tablets in the pack because it's not taken for long. Next slide. So once it's a structural problem, like I said before, you go for surgeries. If it's a structural problem, it has to be corrected. If it is stenosis, if it is ductal tube blockage, if it is uterine problem, you need to see a specialist and undergo surgery. Next slide. So for the man, these are the drugs used. The same clomiphene straight that are used in female. There was a friend of mine that go a lot. A man came in with a prescription of clomiphene. I was like, who is taking this drug? He said, I'm the one that's sick. He said, but men don't take clomiphene. But actually, the men do also take clomiphene, but at lower dose and longer time. It's found out it increases the levels of testosterone by decreasing the level of estrogens. So that is the mechanism of action. You will lower the estrogen and you increase the testosterone. Indication is it's indicated in people that have hypogonadism or idiopathic oligospermia, that is low sperm count. The dose is between 25 milligram to 50 milligram daily for 3 to 6 months. Letrozole, virtually the same mechanism, which reduces the level of estrogen and increases the level of testosterone, and you will get once there is high level of testosterone, you increase the chances of man fathering the child. Then follicle stimulating hormone, it stimulates spermatogenesis. That is the process of sperm production. So it's usually given in combination with human gonadotropin. Then the indication is in severe hypogonadism, and the dose is it's an injectable. So it's 75 to 150 milligram IU subcutaneously 2 to 3 times per week. It depends on the level of the testosterone. Next slide. The same HCG that we talked about in women, so it's also used on men, and it's in men. All we are looking at is to increase the level of the testosterone by decreasing the level of estrogen, while in female you will decrease the level of estrogen so that you have high level of follicle stimulating hormone, so that you have more eggs, matured eggs for fertilization. Then carbagolin, just like in women, there can be men with hyperproteinemia. Like I said, you see a man with a large breast or producing milk from their breast. That is where you use carbagolin to reduce the prolactin level and lower the hormone, and that will now increase the testosterone level. It will decrease estrogen and will now increase this testosterone level. Then we have antioxidants like vitamins and minerals. We have vitamin E, we have zinc, we have selenium, we have so many of them that you ask a patient, a male patient, to be taken daily to increase the quality of the sperm, because stress reduces the quality of the sperm. So these antioxidants, they reduce the oxidative stress on the body and now increase the quality of the sperm. So these are the range of the doses. Like vitamin E can be taken 400 IU to 800 IU or even 1000 IU every day. So for those couples, the drug treatment failed, you advise them to go for ART, that is assisted reproductive technology. You have tried maybe 3 or more cycles of clomiphene. You have tried letrozole. You have tried these injectables with gonadotropins, but still there is problem. Or you don't want to try anything. You just want to do ART. It's acceptable. It depends on the choice of the couple. So procedures using ART provide a valuable treatment option for many couples who are not candidates for COS alone or intrauterine insemination. Couples that are not candidates for those drugs, or couples that are even the candidates but they don't want to use the drugs, they can go for this. Probability of pregnancy in healthy couples is about 30 to 40%. That is 30 to 40% per cycle. And it results in live birth rate up to 30%, meaning that once you have an ART, it doesn't mean that it's guaranteed that you're going to have a child on that very cycle. So per cycle is 30 to 40% chance. For example, literally, you can say out of 10 people, 3 to 4 people will have success rate in one cycle. And that will give them, they will result in live birth of up to 30%. So it means that once you can fail. So if it fails, you have to do it again. Still, in that cycle, you still have that chance of success. If it fails again, you go again. That is how it's done. It's not like 100% once you have an assisted reproductive technology that that very cycle will result in pregnancy and live birth. So the data ranging regarding birth defects remain conflicting. Some data suggests that or prove that this assisted reproductive technology produces children with birth defects, while some say no. So it's conflicting data. What are some there's some studies reported up to 30% risk of congenital abnormalities. So it has to be an expert, a specialist that will weigh in and decide. And now in consultation with the couples. Let's go. Next slide. So and now assisted reproductive technology also allows couples to use donor sperm or oocytes donation, meaning that this you can if you have, for example, maybe on a job site, on a lighter note, you have an athlete maybe Michael Jordan, for example. You want your child to look like Michael Jordan in size and fitness. You collect a sperm of Michael Jordan and now use it so that you get the traits of Michael Jordan. And for example, for the woman, if you want a daughter, for example, to be like Kim Kardashian, or this is on a lighter or on a lighter note, you can get oocytes from that particular woman that you want their trait in your offspring. So that is one of other advantage of this assisted reproductive technology. It gives you that option, so that either you have a low quality sperm, or whether it's low or okay, they have the choice of getting a donor. So the option of using donor oocyte uniquely targets infertility due to diminished ovarian reserve. When the woman has diminished ovarian reserve or cannot ovulate, you can use this method. That is, you can get a donation of the oocyte and use it. So recent data now documented that the use of donor oocyte in only 3% of ART procedures in women younger than age 35 years, meaning that women that are less than 35 years, only about 3% go for donation of oocytes, while in women that are more than 35, more than 44, the rate of the donation, the people that go for donation is up to 71%, meaning that because there is already the diminished ovarian reserve, the woman is already has lost, the couple have lost hope that the woman oocytes or eggs can do it, can work. So they now go for donation. They request from other women. Next slide. So this is the indication. I don't know that you can see the percentages. Indications of the assisted reproductive technology. We have 12% is as a result of ovulation problem, and the woman cannot ovulate. About 15% is from endometriosis. About 9% is from unexplained infertility. 26% from tubal factor infertility, while 27% from male factor. These are like indications why people go for this ART as a choice. Next slide. So the procedure now, how is it done? The number one, it starts with a retrieval of the oocytes after the control ovarian stimulation. You use your, remember we mentioned clomiphene. You use your clomid to control how many eggs you have, so that you have multiple eggs. That is, you control the process. So you now retrieve the oocytes. All the eggs that are matured, you now collect them for fertilization outside the body, that is in vitro. So you now transfer these collected eggs or oocytes of the embryo directly into the uterus. Now you fertilize. When you take the eggs and you take the sperm, you fertilize outside. You now take the embryo and put it back into the woman's body and implant it in this fallopian tube, so that it will now go for normal implantation on the uterus. So there is also, that is one procedure. That is, you just fertilize, put it back into the fallopian tube, and now it will go back to the uterus. Then we have intracytoplasmic sperm injection. That is the injection of the sperm directly into the oocyte during fertilization process. It accompanies IVF if severe sperm dysfunction is evident, meaning that if the sperm is too weak, so you fertilize outside, you still now take the sperm using an injection and administer it into the woman's body for another fertilization, so that you like combining two ways. So for most couples, it's generally regarded as safe and effective procedure. ART is safe and effective. Next slide. So alternative procedures include gamete intrafallopian transfer and zygote intrafallopian transfer, which alter the timing of fertilization and location of transplantation. That is, you alter the time of fertilization and location of fertilization by administering the zygote. Then in gamete transfer, what happens is the retrieved oocytes are transferred with the sperm to the fallopian tube to allow for natural fertilization. While in zygote transfer, the oocytes are fertilized outside in vitro, then they are now transported back to the fallopian tube rather than the uterus. It is not implanted in the uterus, it is into the fallopian tube. Now it will now take natural course back to the uterus itself. While in gamete transfer, the gamete and zygote transfer procedure are associated with slightly lower live birth than implanting the embryo on the uterus, because if you implant it in the fallopian tube, you are like mimicking the natural system. Still, once the fallopian tube is having problem or the uterus has problem, there could be trouble. But once it reaches the level that you just implant it on the uterus, you get better results. That is what this is all about. Next slide. So this is like diagrammatic explanation. Number one, you get your sperm and the egg, you fertilize outside. That's ovarian stimulation. So number one is ovarian stimulation using hormone therapy. You use clomiphene or letrozole. Then number two, you now pick the egg and you collect your sperm from the man. Now you fertilize outside. You now transport the embryo back to the uterus. That is the procedure. So in other procedures is you don't transfer the embryo, transfer the zygote. That is an earlier stage of development than embryo, and it gets to fallopian tube instead of uterus. This one explains how it goes to the uterus. This is the, I don't know whether you can see the diagram very well, but it explains it like very simply. So the procedure is performed by experts, and like I said, it's 30 to 40% chances per cycle. Each cycle gives you 30% chance that the woman will get a child in that cycle. If it is failed, you now go ahead and you go for another cycle. Next slide. So still in your ART, still you have to use these drugs. Now, because we mentioned the stage, number one, you have to stimulate the ovaries using your clomiphene or letrozole or gonadotropins. The aim is to stimulate the follicles and get more than one egg. Then you now retrieve them. Number two, in oocyte retrieval, you use HCG, which now mix the LH such, where you have the eggs are shaded outside their let me say cover. That's what luteinizing hormone does. So that is why you use human chorionic gonadotropin for. That is in stage 2. Then in stage 3, you use progesterone. Progesterone is what makes the uterus viable for implantation. It will keep the nutrients, it will keep the blood ready for implantation. That is why once there's no fertilization, there will be shedding of that blood that the uterus get chips for fertilization. In the absence of that, that is when you have bleeding. That is menstrual cycle. So once there's fertilization, you don't get that. So that is the work of progesterone. So you give an external progesterone to do that for you. Next slide. So we have seen the causes, we have seen the types, we have seen the medication that are used. So also there is psychosocial aspect to infertility. I don't know whether we have among the participants or among the participants where there are someone that is having this problem, and if you are to sit down with them, they will tell you how difficult it is to internalize that they cannot give birth. That the society look at them as like less of human beings. If a woman is infertile, people look at her as like less woman. If the man is having problem, people look at them as less manly, like they cannot even produce a child. So it places a great emotional burden on the couple that cannot produce. So this is complicated by potential side effects of medications as well as the baseline mental health of the couple. This means that these medications, for example, the clomiphene, the letrozole, all these hormones, they can cause mood swings. So if a woman is using them or a man is using them, there can be mood swings. So couples that are undergoing infertility treatment should understand that the drugs can cause mood swings, and they should understand that it's not themselves, it's not their partner's behavior that is that. So they should be, more receptive when dealing with them. So the quest for having a child becomes the driving force of the couple relationship. Once there's no fertility, once there's no pregnancy, the whole aim of the marriage will be centered on that pregnancy. The couples will forget every other thing. Life is pregnancy is just one aspect of relationship. So they will just forget every other thing and just focus on that pregnancy. They will lose interest, they will lose pleasure, and so many things. Their aim is just get pregnant, get pregnant, get pregnant. So the mental anguish that arises from infertility is as incapacitating as normal diseases. So don't underrate their pain. Don't undermine their pain. Don't undermine their problem. They are going through a lot. They need support. They shouldn't be mocked. They shouldn't be gossiped at and be looked down at. You just support them and tell them that, for example, in my faith, Islam is that we believe it is God Almighty that provides couple with offsprings, either male or female or combination, like he mentioned that in the Holy Book. So if you look at this faithful side and you console the couple that it's God in His wisdom now decide not to give you any. It's only Him knows why, because He can give you a child and child can be trouble for you. So you just be there for them, support them, and tell them that life is more than just having a child, more than having a child. There are so many things that a person can do to enjoy life, right? That necessarily having a child. So it is important for us and the medical practitioners, and the family members and the society at large to understand that and provide emotional support for these people, for these couples, or for people that undergo this problem, and wish them well, uh, and be there for them. That is where the psychosocial issues. Sometimes you even have to refer them to psychologists or psychiatrists to, evaluate their mental health. So these are some of the references, and so by this means that we have come to the end of this presentation. Sorry, my presentation, and I thank you all for listening to me for I think more than 1 hour now. And I hand you over to Obina. Thank you very much.
Thank you very much, Famamino, for that very extensive and exhaustive cover on this topic, infertility, pharmaceutical interventions. We really appreciate all the labor. I know that would have gone into putting this resource together. Your Thank you, sir. So let me quickly ask the audience, apart from the questions we have on the a few that we have on the Q&A section, is there anybody who has a question I would want to ask from Amino to just give some perspectives to it? We can give an opportunity for at least maybe 2 or 3 people to ask their questions before we take the questions that were already written down. And if you have questions, you can quickly put them on the Q&A section of your Zoom app, and then we can attend to it from there. Yes, sir. Do we have any questions? Anyone? You can indicate by raise of hand, and then we'll give you the opportunity to speak. Okay, so I think I saw a question earlier. I did see one. Okay, somebody asked Maliki Abubakar, and he said, is there a need to give more than one of these medications at a time? Maybe something perhaps to achieve a synergistic effect. Is there, is it advised? What do you think? What's your take on this?
Okay, I should answer it.
Yes, please.
It depends on the mechanism the two drugs work. If the one, for example, you are using clomiphene that works from the centrally from the hypothalamus, and now you decide to use maybe gonadotropins like the LH, the external supply. Yeah, you can do that because there won't be contracting effect. There is no contradiction, the contradictory effect. So it will be like, yeah, like you said, synergism. So uh, if you feel like the clomiphene alone, for example, is not enough, well, you can supplement it with maybe, let's say, FSH, follicle stimulating hormone, and injection of it, so that while you have centrally you have more production, then externally you are giving more of it. So the two will now work together and give you more than one, more of the result you desire. The problem is there can be hyperstimulation of the ovaries, and when the hyperstimulation of the ovaries can lead to other negative things that can affect the fertility rate too. That's where the problem is. But actually, you can come back. Thank you.
Okay. And I think that that control might be regulated with the assistance of a physician. So it's not just something the person takes up personally. I guess so, sir. Hello, sir.
Yeah, I can hear you.
Yeah, I said, and I believe that medication combination will be regulated by under the supervision of a physician. So
Yes,
it's
yes.
not just
Because
okay.
as you are giving the medication, you're also running for hormonal test. You are you are sending for hormonal profile so that you don't overstimulate the ovaries.
Okay. So another person is asking, he said he needs more clarification on how tobacco and caffeine can affect fertility.
Okay, like tobacco and caffeine. Studies have this lifestyle modification or dietary supplements or dietary association of infertility and some diets. There are studies that have proved. When you are doing control trial, when you are doing control trial, like maybe there are things that you have this group that take this and this group that don't take this. So I really cannot scientifically explain why they said caffeine, for example, affects infertility. But I know it has to do with the uh, ability to affect metabolism, because caffeine it works in the brain. It's a stimulator, and stimulators do affect so many hormones, and varying of them from the dopamines, acetylcholines, and others down to the hormones we're talking about. So I think that is where the problem is. While for tobacco, that is nicotine. Tobacco is nicotine that's inside. It's still a CNS stimulator, So I believe I will find out more, and but I believe that it's because of that stimulation of the brain that affects the concentration of the hormones. It's not only sex hormones that they affect. So many hormones, these stimulators affect them. So I think that's why the angle is. That's why they say illicit drugs, these amphetamines, cocaine and other things, because they are also stimulators. I think that is the mechanism of why they should be stopped.
Okay, thank you very much, sir. So Aditya, would you want to take the questions on the Q&A section? Okay, so we have another question from the Kemi Adere. And she says, does anorgasmia also involve the female? Because I was told it's difficult for male and female to have also, or I was told it is difficult for female to have orgasm. So does anorgasmia also involve the female?
Well, orgasm is a natural phase or natural phenomenon that happens in sex. It's expected whether a man or a woman should be able to enjoy sex to the fullest. Like that is the highest point of sexual enjoyment. So for a normal person uh, to not enjoy sex, that's a problem. And orgasm is like the highest of it. So for women, you cannot outrightly say women don't do get orgasm. It depends on the man. Sometimes it's the act of the man that determines whether a woman has orgasm or not. And so then it will be difficult to find out whether it's really the woman that has problem or it is her partner that cannot actually stimulate her that enough to get orgasm. Because for women, sex is more of emotion than physical, while for men it's more of physical than emotion. So that's why we are easier to reach orgasm, to have orgasm than the women. So actually it may get difficult to find out whether it's structurally that a woman has problem or it's the partner that cannot make her have orgasm. So if the man can make her orgasm but she doesn't get orgasm, then there's problem. Then that is a problem. But if that is why I say we cannot. It's difficult to find out whether it's the man that cannot make her or she's the one that has a problem. But
Okay,
if the man cannot but she cannot, then it's a problem.
okay. Yeah, Sadatu, would you take the next question on the Q&A section? Sadatu, are you there?
Hello. It seems I'm having network issue.
We can
Hello,
hear
can
you.
you hear me?
Yeah,
Yes.
we can hear you. Bro.
Hello.
Yeah, from we can hear you.
Okay. Um. Okay. The next question is, what if a lady who doesn't see her menstruation at all? What should be the approach for the lady?
Okay, for a woman that has amenorrhea, that is, she does not she doesn't have a cycle. Well, that's why we say there is you have to take the history of menstrual cycles since Minachi, since when they started having menstruation, what has been the like of it. If there's problem, you have to you there are some women, like very few percent, that do not do menstruation. There is no, it's normal, but it's normally abnormal for women not to menstruate. So you you send for this test, this diagnostic test to confirm where the problem is. So for a woman that doesn't menstruate, there can be more than one factor. So she has to be examined both physically and laboratory to find out what is the problem. Or until it's everything is back to normal, then we say that one is an unexplained problem. And or a woman that does not menstruate means that does not ovulate and she cannot conceive.
Okay, so we do not have any more questions. Okay. Oh, okay. So there are some people who raised up their hands. Dr. Oluwajoba, would you speak? Can you unmute your mic and speak? Yeah, we can take just two. I see Dr. Joba and Chijuke Izaka. Yes, please go ahead. Dr. Joba, can you unmute yourself and speak? Or Chijuke, are you there? Chijuke Izaka, can you unmute and speak? Okay, I guess they're not able to do that, and there's no other question. So we want to we want to bring this conversation to an end. Thank you, Famamino, for really an extensive cover on this subject matter. Thank you, our listeners, for being with us up until this time. We hope that you have learned a few things. The slides will be made available for every one of us who registered. And please, a survey will be sent to you, just a feedback survey that we hope that you can give us some candid feedback on how you engage the webinar and how effective and how wonderful perhaps the sessions have been and what has been your take home, and if there's any criticism, whatever, we'll be willing to listen for that. Thank you very much. Thank you from Amino. We're glad that you could honor our invitation. We'll be hoping to have future more productive collaborations with you and all that you represent. Thank you very much. Thank you, Farm Sadatu, for working with me. So from us at EHA Clinics, it is good evening. Thank you, everyone. Bye.
All right, thank you, Joe. Bye bye.
Bye bye.